STEMI equivalents are electrocardiographic patterns that indicate acute coronary artery occlusion despite the absence of classic ST elevation. Recognizing these patterns is critical because they require urgent reperfusion therapy similar to classical ST elevation myocardial infarction. Step 1. Understand the key concept. Not all abnormal or high-risk ECG patterns are STEMI equivalents. Modern guidelines emphasize that only specific patterns indicating acute coronary occlusion should trigger immediate reperfusion pathways. Step 2. Understand the major guideline change. According to the latest 2025 American College of Cardiology and American Heart Association guidelines, new or presumed new left bundle branch block is no longer considered a STEMI equivalent. This represents a major shift in clinical practice. Previously, new left bundle branch block often triggered automatic activation of the catheterization laboratory. Now it requires careful clinical assessment and ECG interpretation using validated criteria. Step 3. Recognize true STEMI equivalents. First, posterior myocardial infarction, ST depression in leads V1 to V3, particularly horizontal depression, may represent posterior infarction rather than subendocardial ischemia. Additional features include tall R waves and upright T waves in these leads. In suspected cases, posterior leads V7 to V9 should be recorded. ST elevation in these leads supports posterior myocardial infarction and indicates the need for urgent reperfusion. Second, the De Winter pattern. This is characterized by upsloping ST depression at the J point in the precordial leads, combined with tall, symmetrical T waves. This pattern reflects proximal left anterior descending artery occlusion. Although there is no classical ST elevation, this is a true STEMI equivalent and requires immediate reperfusion therapy. Step 4. Evaluate patients with left bundle branch block or paced rhythm. The presence of left bundle branch block or ventricular pacing alone does not diagnose acute myocardial infarction. Instead, the diagnosis relies on Sgarbossa or modified Sgarbossa criteria. The original Sgarbossa criteria include 3 components: concordant ST elevation of 1 mm or more in leads with a positive QRS complex, concordant ST depression of 1 mm or more in leads V1 to V3, and discordant ST elevation of 5 mm or more in leads with a negative QRS complex. A total score of 3 or more suggests acute coronary occlusion, although sensitivity is limited. The modified Sgarbossa criteria improve diagnostic accuracy. They retain concordant ST elevation and concordant ST depression, but replace the third criterion with a proportional rule. Excessive discordant ST elevation is defined as ST elevation of 1 mm or more, with an ST to S-wave ratio of -0.25 or less. Only one criterion is required for diagnosis. This modification significantly improves sensitivity while maintaining high specificity. Step 5. Recognize early or evolving occlusion patterns. Hyperacute T waves are broad, tall, and symmetrical. They may represent very early coronary occlusion before ST elevation develops. Although not always classified as formal STEMI equivalents, they should raise strong suspicion and prompt urgent reassessment. Transient ST elevation is another important pattern. If ST elevation appears and then resolves in a patient with ongoing symptoms, this may reflect dynamic coronary occlusion and should not be considered benign. Step 6. Identify high-risk patterns that are not STEMI equivalents. Wellens syndrome is characterized by deeply inverted or biphasic T waves in the anterior leads, especially V2 to V3. It typically occurs when the patient is pain-free. It indicates critical proximal left anterior descending artery stenosis and carries a high risk of extensive anterior myocardial infarction. However, it does not represent acute coronary occlusion at that moment. Stress testing is contraindicated, and early invasive evaluation is required. Another important pattern is ST elevation in lead AVR with diffuse ST depression. This suggests global subendocardial ischemia, often due to left main or severe multivessel disease. It is a high-risk finding requiring urgent evaluation, but it is not classified as a STEMI equivalent in isolation. Step 7. Apply a practical clinical approach. In any patient with suspected acute coronary syndrome, obtain an ECG immediately. If classic ST elevation is present, treat as STEMI. If ST depression is seen in leads V1 to V3, consider posterior myocardial infarction and record posterior leads. If left bundle branch block or pacing is present, apply Sgarbossa or modified Sgarbossa criteria. If de Winter pattern is present, treat as acute left anterior descending artery occlusion. If hyperacute T waves or transient ST elevation are seen, repeat the ECG urgently and correlate clinically. If Wellens pattern is present, avoid stress testing and arrange early angiography. Always interpret ECG findings alongside symptoms, hemodynamic status, and cardiac biomarkers. Step 8. Final summary. High-risk ECG patterns do not all carry the same implication, so they should be interpreted carefully. Hyperacute T waves may represent very early acute coronary occlusion and should prompt emergent coronary angiography when seen in the appropriate clinical context. Wellens syndrome also requires urgent recognition. It indicates critical proximal left anterior descending artery stenosis and needs early invasive management with coronary angiography and revascularization. Stress testing is contraindicated because it may precipitate acute myocardial infarction. ST elevation in lead AVR with multi-lead ST depression is more variable. It may reflect severe coronary disease, global subendocardial ischemia, or supply-demand mismatch. This pattern requires nuanced management. Emergent angiography is particularly indicated when there are persistent ischemic symptoms despite treatment or hemodynamic instability.